be with us in person has been called off to something else, but she's very kindly done a video presentation for us, which is exactly what she would have been presenting. The only difference will be that we can't actually ask her any things in real time. So what I'm going to do is to share my screen and play the video. She, at the end, you will see that she actually says, if anybody wants to ask me any questions, please do. So if you would like to ask her any questions, what I suggest is that you put them in the chat bar or the questions and answers bar, and then we can collate those and pass those on to Mel. So some of you know Mel. She's a consultant psychiatrist and psychotherapist. She's completed work within the field of trauma psychotherapy and interventional psychiatry since 1999. She's an EMDR UK and Ireland consultant, supervisor and practitioner, and also an IPT UK accredited practitioner. So Mel's going to kick off by giving us a talk about dissociation, and then she's going to interview somebody with lived experience who's very kindly agreed to contribute to this session as well. And I'll let Mel introduce her to you. So I'm going to now share my screen. I've been advised to make sure that I click on the sound button. I include computer sound. Here we go. So I'm going to want to get some early feedback that you can hear this, of course. So if somebody could just shout out yes or no once you hear Mel speak, that would be great. To let you know, this first video is going to be just over 1 hour long, and then there's going to be about 25 minutes of an interview. We'll then have a pause for about 15 minutes, and then Marylene Cloitre will give us a talk, and Marylene is going to be joining us in person.
Okay, so this is I'd like to thank John for inviting me to talk today. My name's Marylene Temple. I'm a consultant psychiatrist, psychotherapist. Today, it's sort of an introductory session on dissociation, thinking about kind of what it is and how we might see it in practice, and some real basics around what you might do. We've also then, as part of the session, got a video of a conversation with an ex-patient of mine who experiences dissociative identity disorder, which will really add to the flavour of the meeting today. So I'm just going to try and share my screen. Okay. So hopefully this is now working. So as I said, this is an introductory session. Obviously, we've only got an hour of this part, and then we've got half an hour on the discussion. There's a lot to be said about this. It's actually a very big topic, so I apologise if some of you find we haven't covered everything that you might want. This is very much an introduction. There's a lot more to be said in terms of treatment, particularly if you get into the complex areas. Obviously, if there are more questions, please do let John know, and we can kind of consider from there. Start with a disclaimer. I do not consider myself an expert in this in any way, shape, or form. I am what I would class as a jobbing clinician. I have, over time, ended up working with more and more complex patients with considerable levels of dissociation through to running a complex trauma unit for patients experiencing severe dissociation, including dissociative identity disorder. And you'll hear Karen talk about the Kemp unit, which used to be part of the retreat in York, which was an inpatient treatment programme, which looked at DID and particularly managing high-risk patients with DID. So I'm not a researcher, I'm not a professor or anything of those sorts. I'm just a clinician who has had the privilege of working with lots of these patients. The second part of this is definitely not all my own work. As a clinician, I have done lots of training, read lots of books, attended workshops, had supervision from and used this is material from lots and lots of people, including one of the people who you will be saying after me today. So really, I'd encourage anybody who's working with patients in this area to actually read as widely as you can, go to as many of these workshops as you can. There isn't any specific course on this, and maybe there should be, but certainly it's about finding out as much as you can and having lots of tools in your toolkit in terms of where to go. So when we're talking about dissociation, what are we actually talking about? As an experience or a symptom, the simplest way to think about is a lack of connection between things that are usually connected. Dissociation is actually instinctive. It's something that's natural. It's considered adaptive, and all of us have the potential to do this. Most commonly, it's developed as a strategy in childhood, and it's rarely learned as a coping strategy, or certainly learned as a main coping strategy after 10 years of age. It is made up of both psychological and physiological aspects, and it's generally activated for us when an experience is perceived to be either overstimulating, too distressing, painful, traumatizing, life-threatening, and sometimes sort of understimulating if you think of the idea of daydreaming. What does it do? Well, it serves to minimize awareness of different aspects or effects of an experience, or in the extreme, it actually disconnects you from the entirety of an experience. In doing that, it actually allows you to focus on whatever within the tasks that are necessary to complete that, to survive, to manage an experience in a way that actually allows you to keep going. So in its essence, it's a brain sort of survival response, and to look to escape something if indeed escape's possible. And most people would put forward that severe dissociation is the brain's alternative when the mind is overwhelmed by fear, powerlessness, and a sense of no escape. Dissociative experiences are very much a spectrum. They go from what would be considered normal to those that are considered to be disordered and part of dissociative illness. Interestingly, the presence of dissociation actually predicts poorer outcomes for people experiencing trauma and for developing PTSD, and indeed for the complexity of the PTSD. And that came out of research into the Twin Towers trauma survivors. So what is this spectrum? I'm sure all of us have had that experience of being completely absorbed into something where we lose time, where we've been sleep deprived, where you don't actually quite remember getting to where you did or what you're doing. When you're doing a journey on the motorway that you do all the time, you end up taking a junction and you think, why did I actually take that? Not ideal, not necessarily safe driving, but we've all happened. And the concept of daydreaming, where you sit in the classroom and you're off doing your own thing. So that's the normal sort of elements of it. And then we can think about dissociation as symptoms within other disorders. The classic one we all think about is within PTSD or complex PTSD in terms of flashback phenomena. But you can also see it within sort of attachment developmental trauma-based difficulties, such as in borderline personality disorder, where there's a sense of drifting into a different way of functioning, though remaining kind of aware, but a sense of kind of disconnect. You can also then have the more specific dissociative disorders, those which we would see along the lines of kind of the anxiety-based, depersonalization, derealization, and then those which are much more complex. Previously, you had dissociative identity disorder and dissociative disorder not otherwise specified. ICD-11 has introduced the concept of partial DID, and those are for the patients who we probably know quite a lot of, where they meet some of the criteria for dissociative identity disorder, but not all. The key thing for DID is there needs to be amnesia to at least some elements of the dissociative presentations, and there needs to be at least 3 of them. What often happens within partial DID is there aren't 3, or there isn't amnesia present within the actual experience itself. So why would somebody dissociate? Why would they learn to dissociate as they're growing up? The commonest is managing overwhelming emotion, anxiety, distress, shame, fear. Managing physical experience, whether that's pain, whether that's the experience of body distress from what's happening to them, and also in relation to sleep deprivation. It might be about managing your environment, about disconnecting from where you are, being able to escape this or tolerate what's happening within your environment. And it might also be in terms of managing an interaction with another person and to basically escape that interaction. Needless to say, it can be all of those all at one time, or individually. And when you start thinking about this, you can start to think for an individual who has a tendency to dissociate, those are things that happen to us on a daily basis in our lives, and therefore actually the likelihood of dissociation being quite high. So what about the complex disorders? And when we're thinking about those, this is where we're in the realms of sort of partial DID and DID. Well, they actually are understood to occur from a combination of things, but more specifically, repetitive early childhood experience of traumas where there is acute hopelessness and helplessness. It's an interpersonal trauma whereby somebody who is meant to care for you and look after you and protect you is actually creating harm. And there's a biological response to that within the brain. And if you think about that, actually, a dissociative disconnect from what's happening in that experience, in that trauma, is actually very adaptive, and it allows you to carry on surviving. So the child is experiencing multiple abuses at home. When they go to school and they're disconnected from that completely, they can carry on and function as normal. And indeed, they can go home disconnected from the reality of what's happening, because actually, if that's all dissociated away, then the terror of going home becomes less. The difficulty, of course, is that that dissociation continues as an adult. And then all those areas we've just thought about that happen to you every day, for that adult, they dissociate repeatedly through the day. That means that actually experiences in your adult life, which should be safe, which should be fine, actually are instinctively responded to as dangerous, which means that the dissociation happens. Now, that, as you can understand, will have a significant effect on your ability to function in your day-to-day life. So why are we so interested in this? Why is dissociation a problem if it's natural? And this comes down to how we make sense of ourselves, how we process experience, how we understand what's going on in our lives and around us in the world. And then actually our identity, our experience of reality, our experience of time, and our processing experience depends on all of those different elements being available to us to use in terms of kind of understanding things. So if dissociation is what you are using to manage your day-to-day experience, you're going to have big gaps in either the thoughts or the sensory experience or the bodily experience of what was happening. And in doing so, then the experience of yourself, of your memory, of the world around you becomes disjointed and fragmented because you haven't got the whole picture. And in working with patients, we often talk about kind of the experience of the world and the self as a jigsaw, and what dissociation does is it removes pieces of that jigsaw, which means that when you're trying to understand yourself and what's happening and what's going on around you, actually you've got an incomplete picture. So thinking on why is this then a problem? Well, not surprisingly, is when you'll hear from Karen, it's a cause of significant stress. It can impact on all areas of your functioning, relationships, daily living skills, trying to engage in education, trying to work, trying to drive. All of these things require the whole picture. And if you don't have the whole picture, then you will have an impact on this. And indeed, At the same time, if you're disconnecting from a conversation because you're feeling activated by what's going on within it, then you can't engage in the conversation, you can't remember the conversation, and that repeatedly on a day-to-day basis, you can imagine is going to cause problems. If we then think along the lines of, well, okay, that's for the person, what about for us as clinicians thinking about doing trauma treatment? Well, we think about the sort of the basic constructs for what we need present within a patient's experience to be able to actually complete that trauma treatment. And there are a couple of ways I look at this and indeed sort of talk to patients about this. And Joan Experience talks about having a three-legged stool to be able to sit on for successful trauma processing. And within that three-legged stool, you have three legs and a seat. And she talks about the fact that you have to have self-compassion, you have to be able to have attachment-based relationships, and you need to be able to have emotional experience, tolerate this, and be able to kind of work with it. And then your seat is the arousal management. I must say I would also add the body connection. But actually, if you start to then think in each of those areas, you can dissociate away from them, or the dissociation itself disrupts the ability to do those things, then actually you might struggle with doing any trauma processing. Paul Levine then obviously has his Simon model for event processing, adds in each of the areas, and anybody who's certainly doing EMDR in the audience, I would really stress to you the importance when you're thinking about starting any sort of processing with a patient, are all of those aspects present? Because if they're not, you can't process and you won't be able to process. And often when I've been doing any sort of consultation or supervision where somebody's really struggling and the patient's looping and they're saying, oh, well, you know, it's not working. When we come down to it, there is a disconnect in one of these areas, and therefore the patient is unable to progress. So that's all very well, but how do we actually understand this whole process? And certainly, probably many of you is aware that, you know, actually still the concept of dissociative disorders, or indeed at one point dissociation itself, was contested. And in fact, when I was invited to and wrote an article for Advances in Psychiatric Treatment about sort of review of dissociative disorders and treatment of dissociative disorders, there was an interesting response in terms of different people being very upset that the psychiatric press had even decided to look at printing this. And to be fair, the response to that was quite difficult, and particularly difficult for service users I was working with at the Kent unit, to the extent that one of them asked if I would do a response to that with her, and indeed we published a response. We had a response published in the journal, which kind of, I suppose, at least gave the patients their voice in terms of this. So if we're thinking of a kind of a theory of around dissociation itself, for me personally, I think the polyvagal theory and thinking about kind of the parasympathetic sympathetic response in our brains and in our bodies is probably the best way of understanding it. And the idea that actually at the very basis of our very bottom response is this actual disconnect. Right up the top in our sort of most evolution, we have attached, cry for help, engage, social with others. Then you've got the expected kind of fight flight that everybody knows about. And then underneath that is where dissociation sits. And I think one of the things I talk about with my patients when we would start to talk about it, so we talked about, you know, responses you see in animals. So when you see kind of antelope or chickens with foxes, you'll often play dead. And then the fox isn't interested and they leave them, and then the animal comes round. So this is something that kind of makes sense from a sort of a biological, anatomical, and physiological perspective. In terms of understanding the disorders, in particular, trying to understand what is going on within sort of dissociative identity disorder or partial DID, the structural dissociation model is probably the best way to think about it. And this looks at the concept of dissociation creating a split within us in terms of our experience of ourselves, and where we place elements of the experience and the responses to that experience, and the other part of us that actually manages. There's lots of discussion around whether the original comments of emotional parts and apparently normal parts are helpful in terms of definitions, but actually for me, I tend to talk about the part that holds the trauma memory and the trauma response, and the part of you that tries to get on and survive and function in day to day. So what does this look like if you're trying to conceptualize this? If we think about that kind of first level, and this is when we're thinking about sort of simple PTSD, you've got a traumatized part of yourself which sort of disconnects from the other part and tends to be pushed to the one side, and we try and not connect to that, we try and avoid it, we try and stay away from it in order to keep on functioning. When there is this crossover and overlap, this is where you get re-experiencing, this is where you get kind of the flashbacks and the kind of the working of the brain trying to bring the two together. And interestingly, it's that overlap point that we look to work with within our trauma therapy, in the end, the idea of bringing the two back into one. Secondary level dissociation is where, and this is for me a really lovely way of thinking about complex PTSD and what happens in emotionally unstable personality disorder and in patients with kind of more partial DID, is where you still have in effect one functioning, getting on and trying to live with life part of yourself, but then you also have more than one of these traumatized parts of yourself, which often holds different components of different traumas and will have different responses and will be activated at different times. So this is the patient who kind of ticks along quite nicely, and then they'll have a particular interpersonal interaction, or they'll have an experience of high levels of emotion, or they'll have an experience of failure or something happening, and that activates connection to one of these areas, which then activates the same kind of that sort of response pattern in the moment. The severity of this can be extremely variable, and for some patients, particularly if you're getting into the realms of partial DID, they'll talk about feeling that this is actually this. There's a part of themselves that takes over. There's a part of themselves that actually is like, I'm doing this, but I don't feel like this is me. But actually, there isn't any of the amnesia. There is actual kind of awareness of what's going on. At a more simple level, there's a noticing of I keep doing this behavior, I keep doing that behavior. In this situation, I'm like this person. In this situation, I'm like this person, but they experience it as themselves. So a really nice way of helping somebody with kind of complex PTSD and EUPD to understand the different sort of parts of themselves. And if anybody is CAT trained, the kind of the whole reciprocal roles sort of discussion about one person acts like this and then you behave like this, and one person acts like and you behave like that. This sits with that sort of model of understanding really, really nicely, and is a really helpful way of kind of understanding with patients how they're doing. So I think the final one, and to be fair, the way this is drawn out, I often think rather than the personality being up there, the three AMPs are actually the personality, and this is the whole. So the actual yellow circle represents the person as a whole. So if you're thinking about Karen, who you'll see in the video, the yellow represents Karen as herself, the whole person. And then within her, you have these different kind of component parts of herself which function completely and utterly independently, can completely take over, and she will be amnesic to them. Now, as you'll hear from Karen, she has had some connection with some parts, had no connection with other parts, and over time developed connection, which is often what occurs through sort of therapy. But as you notice in there, you start to have different parts that function for different sort of environments, as well as kind of the traumatized elements. And the thing that gets very complicated in this is there's a level of disconnect in so many different areas that can get quite mind-boggling at times, and sort of needs some careful kind of work and understanding. There is a final bit to talk about, which again seems to be a bone of contention, but when you've worked with one or two of these patients, you suddenly realise, well, no, this is definitely a real thing. And this is the context of sort of the fourth level of dissociation. And this is made dissociative systems. And this is where you get into kind of ritualistic and organised base of use systems, often thought about in relation to kind of religious cults and this side of things, but there is evidence of this within military and paramilitary type child abuse and child soldier settings, particularly within Africa and within the Middle East. And there is the use of extreme pain, extreme fear to actually create dissociative parts, which are then further worked with to create a response. So it's almost using the brain's natural response to then create a response that the particular organisation would wish within that individual. The difficulty within it is because it's dissociative, is it's not within the person's awareness. It is fortunately quite rare, but it is there. There are one or two books on this which are quite a disturbing read. So I would say it's something to look at if you happen to work with a patient where this becomes clear. But actually, it is a piece of work which can be extremely distressing for the therapist and requires a lot of supervision because of the intensity of the trauma that the individual has experienced, and also the level of risk that can come within some of the behaviours. So we're talking about all of this, and there's obviously a lot of contention in relation to whether this is actually a thing, does it exist? And there are an increasing number of neurobiological sort of studies in terms of imaging, in terms of G profiles, physiological profiles, that actually are beginning to demonstrate, yeah, actually this is actually a thing happening in the brain. Most recently, I think it was 2020, might be 2021, there was a European paper from the Dutch team who again demonstrated that there are functional MRI changes within patients. So we would hope that with time and more of these studies, that actually we've got the ability to start moving away from this constant argument, which is, as Karen will say, is particularly unhelpful to patients. So what are we looking for then, if we, in terms of actually thinking about this? And I love this sort of quote from actually a business chap who talked about the fact that the people who are best at noticing notice it because they're actually looking. And we have this thing as human beings called confirmational bias. And if we start doing an assessment, or even at the point we've read the referral and the original history, we've already started to develop bias. So in order to actually be open to seeing dissociative presentations, to be noticing it, you actually have to be prepared to look. So there's a real importance here about actually having the dissociative symptoms as part of your discussion. So the concept of amnesia to events, the concept of disconnect and dissociative symptoms, depersonalization, derealization as part of the repertoire of questions is actually really important. And yet most of the time they aren't taught, and it's not what we're used to, therefore we're not looking. So, you know, the more you work with patients, the more you notice dissociation, the more you see it, basically. And certainly having done 6 years working in complex trauma dissociation specialist service, I certainly see it more quickly now than I ever used to. And in fact, that there were several times after I started this thinking, oh, actually, that patient probably, and started to notice and suddenly realizing I hadn't been asking questions. So, you know, what might this look like? If you're asking, what might the patient be saying? So if you're thinking around depersonalization, derealization, depersonalization, there's often a talk, you know, a description of sort of floating, the world on themselves kind of feeling unreal, a sense of sort of out-of-body experience, the world moving around you, things not feeling right, not feeling real. It might be that parts of themselves feel disconnected or not quite right or doesn't feel mine. It might be, particularly if there is an element of sort of DID or partial DID going on, there may be an experience of passivity, which is where you feel that there are other parts of you being kind of controlled or out of your control. You may have hallucinations, you may see things, you may hear things, you may, you know, and that can vary enormously as to what that is. In terms of somebody's sort of affect or facial responses, you may notice that it's very flat, it's very disconnected. It seems like there's nothing going on. Or equally, if, and one of the things you notice very much and you really feel with somebody who has DID is their affect seems to be all over the place. They're just like everywhere. One minute they're really flat, and the next minute they're really expressive, and it's really changeable. And then it goes flat again, and then it might be very fixed and in one particular way. So very changeable or nothing. Equally, belief systems can be there, and one time you see the patient, there'll be one set of belief systems, and then the next time you see a patient, there might be other belief systems. Self-harming behaviors are uncommon. Extreme responses to emotions, to interpersonal situations. Shame very commonly creates a response. Mood dysregulation, voices, internal, external, derogatory command. And you can see when I'm describing this that actually, again, if you think of that sort of confirmation bias, you're going to be going down the line of, well, this is a schizophrenia, this is a bipolar, this is an EUPD, this is and indeed there might be that, but actually there also might be a depersonalization, derealization. There might also be a partial DID or a DID presentation in addition to other things, or they might be there in the room. So starting to get this idea that actually it's important that we start to really notice and ask the questions looking for dissociative disorders as well as what we might otherwise be noticing. So let's get on to there's a real hot topic at the moment, and I don't know whether it's the same amongst your group as well. Okay, so what's the difference between psychosis and dissociation, psychotic disorders, dissociative disorders? So we go back to basics, and Karen was really helpful here because she actually describes this in the video, so it would be good for when you sort of see this. Psychosis or psychotic symptoms and the experience in which thoughts and emotions are impaired, and there's a loss of contact with external reality. Classic psychotic symptoms, hallucinations, delusions, and disordered speech and thinking, and there's different variations of all of that. The Charity Minds definition is a psychotic experiences when you perceive or interpret reality in a very different way from people around you. You might be said to lose touch with reality. But then if we go back to the beginning, isn't Dissociation disconnects from things that are too normally connected. So if we're normally connected to reality, isn't dissociation a disconnect and therefore a psychotic symptom? Well, the interesting thing is the flavour of what that experience is. And Karen describes this just so well in the video. And it's basically within a dissociative symptom, and you could describe it as psychotic, say the voice hearing, they're often identified as part of not normal reality. So they're hearing it, it's a real experience, but it's recognized as not a normal experience. Whereas actually within the psychotic illness, say a depressive psychosis or within schizophrenia, the experiences are unquestionably considered part of reality. This is real. There isn't this idea that this is weird, this is a bit mad, not quite sure, don't like it. So it's when you're trying to decipher between the two, actually that experiential element seems to be, certainly for me as a clinician in working with patients who often had one or the other or both, the bit that actually separates it is the actual experience of something being actually real versus, yep, I'm having this experience, but it's still a bit weird. So that said, can you get psychotic experiences from a dissociative disorder? Yes, mostly out of DID. And often within that, you can still make sense of it in some way within the context of the disorder itself, but also in context of the trauma. So an example, we had a patient who used to see sort of snakes in the carpets. That was considered initially to be part of possibly a schizoaffective disorder or a very, so that sort of idea or a psychotic symptom, but actually within the context of the disorder, and she was seeing them, so it was a hallucination, a psychotic symptom, but actually it was coming out of a memory of having been given a hallucinogenic drug as part of her childhood abuse experience. So it can actually be really complicated. And the bit that's also interesting is that psychotic symptoms which seem to come out of dissociative disorder seem to be much less responsive to medication than, say, those that might be part of depressive psychosis or sort of mania or schizophrenia. So very interesting, but you can have both. So I have a patient at the moment who has schizoaffective disorder, who has derealization, depersonalization, and equally has two different sets of voices, some which relate to childhood trauma and some which most definitely don't, by her report and experience, and they are experienced differently. So not quite as clear cut as we would like, but there does appear to be a difference. And certainly when you hear Karen's description of what feels different, it's very noticeable. Now, the most interesting thing for me in Karen's experience was that Karen herself experienced the psychotic symptoms, but the rest of her dissociative experience system didn't. And in fact, they were noticing and saying to me, well, I don't know what that's about, because that's nothing to do. We didn't do any of that. We didn't have any of that. That's wrong. That's strange. But when she was very severely depressed and had retardation symptoms, the system did experience those. So the biological bit seemed to be experienced, but that psychotic bit wasn't. Absolutely fascinating. So what on earth is going on in that brain when this is happening? Who knows? But really, really very interesting. Another thing that I'd really sort of raise with you in terms of really noticing and looking for dissociation is there are sort of three real kind of experiences that we might have as human beings interpersonally, which are quite highly linked with dissociative coping. Invisibility, being seen, or connected to another human being is an intrinsic need. We are absolutely wired for this. And not being seen, being invisible, or needing not to be seen, because when you are seen is dangerous, activates threat systems within us, because actually we need this. It's linked to intensive emotional pain. It's linked to the development of cognitive cognitions about not being good enough or worthy and lovable, and in turn then is linked to high shame responses. Dissociation is really, really, really common as a response to this in children. So where you, within your history, you're hearing about kind of the need to be invisible because it was dangerous, or being invisible because either everyone was too busy or there was too many other things going on, or parental illness, then start to notice a little bit more and maybe ask a bit about dissociation. Where there is pathological guilt, and by that I mean somebody where they had to do something to survive, there wasn't an option. Feeling guilty, so the classic sort of child, I did something wrong, it's my fault, when actually clearly it wasn't. But it's safer to feel that if only I, and that position of guilt. Again, because that's so hard, it's linked to dissociating. So I'd really sort of notice if you've got high shame, high guilt, and this invisibility, for me, at least a level of internal dissociation is normally present. So just thinking about sort of how often is this happening? Well, it's difficult to say, to be fair, because actually the studies are mainly kind of US based, they're mainly based within actual populations of patients. It's not really replicated across the world, so you get sort of 0.1%, 1%, difficult. So I tend to kind of say, well, it's probably more prevalent than we realize. Certainly when you start getting into patient populations, actually, particularly you start looking at borderline personality disorder, complex PTSD, there is probably quite a lot of it. US studies looked at unsuccessfully treated borderline personality disorder, formally assessed them for dissociative disorders, and 76% had an undiagnosed dissociative presentation across all of the different disorders that I've mentioned. If you wanted to kind of hone that down a bit, 56% of those 76% had partial DID, and 38% of that 76 had undiagnosed DID. Now, you might argue that feels like quite a high number, and I agree, it probably does. And the level of diagnostic approach perhaps wouldn't be what I would consider gold standard. But I think what's worth noticing is where we have patients who have been through what would otherwise be considered good treatment for emotionally unstable personality disorder, and they haven't been assessed formally for dissociative disorders, that's something that maybe should happen. Again, US studies, inpatient settings, those patients who are revolving door or an extremely long stay, up to 5% of those were found to have dissociative disorders alongside with other conditions. So again, where we've got, we think about rehab and long-stay patients, probably we need to be looking at this a lot more in terms of understanding. And I think that then fits as well with the idea that it's often 7 years or more before the dissociative disorder is picked up within the presentation. And I do wonder again, how much of this is this sort of confirmation bias? We're looking for things we know, we ask about things we know, and therefore we're missing the things that might also be there, or might actually be the thing that's there that we need to kind of be thinking about. In terms of comorbidities, depression, complex PTSD, personality disorder, really common. Not surprisingly, when you think about the sort of what the person is dealing with and the origins of the disorder. But equally, it's been seen that sort of bipolar or schizoaffective disorder is actually, are common comorbidities, and particularly you start looking at kind of the long stay, the chronic patients, the long door patients. Actually, it's the sort of those sort of bottom three that we're probably seeing more of. So if you're actually working with a patient, you might suddenly be starting to see this, what are the common triggers? And certainly if you're noticing with a patient that they say, oh, well, in this scenario, in that scenario, this seems to happen. I struggle more with interpersonal interactions. I struggle more, high emotions. This tends to happen, that tends to happen. It's really worth starting to think about kind of whether actually this is a dissociative type phenomenon. So interpersonal interactions, in particular, abandonment, invisibility, notice you'll start thinking about possibly emotionally unstable personality disorder, but also the idea that I might need something, I might feel vulnerable, in particular if I might need help. That can often lead to a disconnect with dissociation, particularly where that need has been considered dangerous, or asking for it needs a particular approach because it might be dangerous. And high emotions. So, and if you think about therapy and any sort of work you're trying to do, you ask all of those of a patient. You ask them to interact with you. You ask them to engage with you in a very vulnerable position. You want them to develop a relationship with you, and you want them to experience all these emotions. So if you have a patient who has dissociative tendencies or a dissociative disorder, you can pretty much see why actually we really need to be thinking about this, because actually it's going to be happening quite commonly. Equally, if you're dealing with a patient and it turns out that they have been through one of these sort of organized, sort of really complex ritualistic abuse, then you may also find that sort of trauma re-experiencing itself, or particular words or particular ways of interacting, may activate different sort of dissociative presentations. This can be really strange when you see it. Certainly the couple of patients we worked with on the ward, it almost seemed sort of a robotic type thing. It was very, very strange. Things like when rules such as telling people or informing people, you can often find that activates something. And sometimes that can be a very risk-based behavior. The thing with risk-based behaviors as well is trying to actually understand what is the purpose of it. And quite often self-harming behaviors will be about protecting the patient from something else. If I do this, then this might not happen. And as Karen will say, some of her self-harm behaviors were quite life-threatening, but actually when understood within therapy from the perspective of that part of her, it was a survival strategy, even though it had the potential to kill her anyway. So it can be a very complicated thing to actually kind of understand and work with. So clinically, how do we identify this? It comes back to the basics. It comes back to history taking, and it comes back and asking the right questions and asking the full range of questions. And it comes back to observation. What am I seeing? I'm hearing this. What am I seeing in front of me? And if somebody says yes to a question, ask for examples. Okay, so you said you kind of feel disconnected. Can you tell me a little bit more about that? Can you give me some examples of that? What would I see, do you think? As what has anybody else described it? What did they see? What did they tell you? The obvious one you'll all be using most likely is the DARES. I would say to you to use the full DARES 2, not the DARES taxon, because actually the DARES as a whole gives you a picture of the different areas where the patient might be experiencing dissociation. You can start to pick out, actually, okay, so this seems to be more depersonalization, derealization, this seems to be more than the PTSD. Oh, actually, there's a lot more here that's feeling more. We're getting into amnesic, we're getting into amnesic functioning. So actually, yes, the score is important, but the picture that you get from the DARES as a whole is actually a really useful one. Obviously, if you're getting a score of more than 30, it's really, really important that you actually then do something with that. Actually getting on and then doing a formal, full structural interview. The commonest one, and for me, the one that I think is the most helpful is the SCID for dissociation. It is a recognised formal structured diagnostic interview. Also useful to do the SDQ20, which is the bodily dissociation questionnaire, because as a guide for certainly if you're trying to do EMDR and you need somebody to be body connected, if the score is high on there, your first bit of work is going to have to be getting the patient connected to their body again, or you're just not going to be able to process. Word of warning, not all dissociative patients score highly on the DES. One of my difficult experiences with a patient with severe anorexia was she didn't score on the DES at all, and in fact she actually turned out to have DID. So sometimes a disorder, another psychiatric disorder, in particular like anorexia, can actually be a form of dissociation. You know, if you starve yourself so much that you're just so bodily disconnected, actually that in itself is a dissociation, and so you don't really notice anything else. I'm a very strong believer for a diagnosis of DID that you have to have 2 independent assessors at 2 separate appointments. One, ideally psychiatrist, who's doing a full assessment, history, observation, and does a DES, and a psychologist who does their own assessment and does the SCID, and then the 2 come together. And in terms of the dissociative presentations, actually, it should be consistent in terms of history and reporting. And this allows for a more kind of formal approach to this, so you get less of this doesn't exist, patients making it up. You know, if somebody's really, really unwell, like Karen was, she came in, she's the most unwell patient I think sort of dysregulated DID patient I've ever worked with. I mean, it can't be anything else. You know, and it's really quite striking, but for a lot of other patients, it's not as striking as that. But actually, in order that we can move forward with helping and assisting patients with the right diagnosis, actually, that for me is kind of the gold standard. We are trying to work with we're trying to work with all kinds of psychiatrists around this. There's a working party looking at it. I'm not actually part of it anymore, but hopefully something might come forward, but I think it'll be a few more years yet. So let's start thinking about treatment for complex cases. So where we have dissociation present, this is now a complex case. This isn't a simple one. There are lots of consensus statements around how we go about it, phase-orientated treatment. Marylene later is going to talk about, you know, really looking about this in terms of how we look at it. Equally, you need to think about developing skills. We need to be thinking about how we make the patient safe. We need to be thinking about how we make them function alongside then any work they might do. And then we need to give them a real sense of where life goes. Now, I'm a big believer that actually the elements of phase 3 should be happening right from the beginning. You've got to give the person the reason to keep moving. You've got to develop their life. You've got to help them actually function and move where they're going alongside any of the work they're doing. The classical way of doing this is very much around, we'll do all the resourcing, and when we've done the resourcing enough, then we'll do some processing, and then we might do some more research processing, and then eventually we might start working on where's my life going and what am I doing. Where actually what I found and the feedback from the ladies we were working with was actually, no, I need to have a sense of my life now, in whichever way. I need to have that direction and that where am I going right from the beginning. Otherwise, this just feels overwhelming. So I would certainly say that actually trying to sort of have a sense of that from the beginning feels really important. If you look at some of the survivors' views, very much the sense of, you know, actually try and get the tone set, try and get the understanding of the jigsaw. And Karen will talk about this and talk about that, the importance of relationship, the importance of compassion, the importance of understanding the whole of the person, and that includes the parts. Be respectful of the fact that this dissociative approach, in whatever way it's appeared and whichever way it now presents, whether it's formal dissociative functional identities, or partial, or just in terms of kind of depersonalization realization, this allows somebody to function. So actually starting to really work from that sort of non-judgmental, compassionate, curious position is absolutely critical, because the most important thing you've got to do is get the person themselves to take that position. And if you don't have that position, how are we ever going to get them to do that? And Karen will talk about actually part of how she's moved forward is having developed that for herself. And that came from a starting point of everybody working with her doing the same. So, and Jackie Dillon talks very much about the idea of developing, I am one, even though I might not feel internally and sometimes externally function as one, but actually really beginning to get the sense of it being a whole. And I think, the bottom two quotes for me are really important in terms of actually, reconnecting and actually allowing somebody to really work with that. And the idea and the hope and holding the hope that you can get better is so important. There are no nice guidelines. There's some increasing evidence. There are some consensus guidelines, but really a lot of the time we're in this, let's be honest, kind of making up as we're going along. That's often how it felt, and thinking outside the box. And as long as we're doing that with the patient and alongside them, and we're working with safety, I guess that's the best we can do. The most important thing I would say is that it needs to be a collaborative exercise. That actually the patient needs to understand where you're going at any point in time. There needs to be an understanding of why we're doing what we're doing. That is one of the most important things we can do. So EMDR wise, for those EMDR practitioners around you, if you haven't guessed already, there's poor internal resourcing. There's little or no compassion to themselves, never mind the other parts of themselves. Emotion tolerance and arousal levels. There might even be complete phobia of that. So any emotion, any arousal level leads to dissociation. There may be complete phobia of the body connection. Indeed, some elements of the memory, if you've got a dissociative identity disorder patient, some elements of the memory might be held in different parts. So the idea that you can just get on and process is not quite so simple. You may get lots of looping and activated beliefs and blocking by different parts. The ability to have that attachment, those relationships, may be really limited. In fact, there may be none. The idea of holding everybody outside feels really strong. Inter-session containment, particularly with a DID patient, may start to become really problematic. And being aware of that, being ready for it. At its most extreme, one of the psychologists who came into supervision, her experience had been starting to work with the patient, doing one session of processing, and the patient coming back from the second session, dissociating in the waiting room, and basically walking off then top of the 4-story building and ending up in ITU. And the patient only came round on the rehabilitation ward. No memory of anything. The last memory was being in the waiting room. So, that's a very, very extreme example, and I'm pleased to say not very common, but it sort of outlines the importance of being aware of what's happening and understanding and taking really good history. So, what are the generic challenges? A lot of phobia, a lot of shame about what's going on. I don't want to talk about it, denying it, minimalizing it. It might be they've learned all sorts of avoidance behaviors. If you've got different parts, they may respond very badly to certain things happening. They may interpret things in a particular way and therefore actually have quite extreme response to different things. But to come back to the most basic thing, and in the video you'll see shortly with Karen, relationships are the key. And the relationship you have with the person, the relationships they have around them are absolutely core and fundamental. It's remembering the harm occurs in the interpersonal construct for most of these patients. That is focused on our needs, and therefore healing is achieved through relationships. That might start with you, and then you need to build around it. You need to be very careful in noticing what are their relationships around. And I'm hoping that all of you will have seen kind of the Harvard 75-minute study and the wonderful TED that goes with it. And the basic tenet that actually, as human beings, we are social animals, and that actually relationships and positive supportive relationships are actually the key to what we need to be well, physically and psychologically. And in terms of worrying about, can I do this work? This work's really complicated. Actually, if you at your basis have a strong ability to develop clinical relationships, you are able to get good supervision, then I would say actually you're able to do this sort of work. Key points: consistency. Do what you say you're going to do. Even if it means you can't do something, you say I can't do something. Being boundaries, particularly patients with DID, it's renowned for clinicians to be pulled in to doing things they wouldn't normally do. Have a very clear sense of, okay, this is where I'm at, this is what I'm doing. Supervision is really, really important. The more you work with young parts in particular, the more you work with things, you will, if you're working with a DID patient, you will find yourself pulled, and you need to not do that. Your role is therapist. You'll find people talking about the concept of reparenting. That isn't your job. Your job is to be a therapist. The patient's job is to reparent themselves. Being responsive, modeling positive relational functioning, and that, most importantly, that compassionate, curious, non-judgmental provision. So these are just basics, but actually they are the most important tenet to doing any work with a dissociative patient, because if you go back to the basis of thinking, what are the things that tends to trigger dissociation? If you can hold these, you will assist the patient to learn. So basic treatment approaches: safety, stability, functioning, relationships, self-understanding, compassion, and then your processing within them. So those at the top provide you the ability to provide the space to then do your processing and create the new path. We haven't really got time to think that much around specifically in terms of EMDR, but I would say, as many tools in your kit in terms of resources, every element you can imagine. And if somebody does have DID, and this is the same for any sort of dissociation, this is around, how do I get the person connected? What are the different ways I can help them to connect? What are the different areas where they disconnect? Getting them to keep diaries, getting them to notice, and then starting to try different strategies in order to be able to understand them. Using things like some chain analysis to understand it, using then actually problem-solving approaches to doing it. If it's interpersonal, what are the interpersonal strategies? What about communication skills? What are the things they need to do? Emotions tolerance, body connection, be creative as much as you can. And certainly for me, I was very lucky to work with an art therapist alongside us in the inpatient team. And the phenomenal work that an art therapist and an OT can help you with in doing this is just amazing. Most of us don't have that, and certainly now I'm back in standard inpatients, we don't have that, and you have to be creative. But actually, the resources in these areas are really, really, really important. The next step for me, going back to the relationships, we've got to make sure that the patients have got appropriate interpersonal functioning. Now, interestingly, IPT itself has been shown, has got an increasing research evidence base around treating PTSD without any actual exposure work, which is fascinating and certainly particularly interesting when you start getting into complex trauma. So really encourage you to kind of have a look at it. And most importantly, have a look at some of the skills aspects around interpersonal functioning, because our patients, particularly dissociative patients where it's interpersonally triggered, that actually they need these skills to be able to move forward. And again, thinking about that attachment leg, this is the stuff we need to be doing to make it work. CFT, we used to have CFT going on compassionate mind training for all of our patients. There is an interesting, Angela Kennedy's done a sort of a CFT sort of focused EMDR approach, but actually, to be fair, the compassionate mind training as a basics actually works really well. And this, for me, has to be part of it. And indeed, a feedback from one of the DID patients I worked with, her view was the interpersonal work and the compassion-focused work, both compassion to herself and to her system, were the two elements, never mind all the processing, were the two elements that actually got her better and functioning. And then if you're thinking about doing the actual processing, I would stress, from lots of experience these days, I would only look to work on what actually affects the patient now. What is causing the difficulty now, whether that's activating parts, whether that's particular flashbacks. Focus on those. And if you don't need to do anything else, don't do it until you need to. That's a very personal thing. And certainly if you're trying to achieve, Karen talks about wanting to achieve the idea of fusion, which is everything all coming together rather than just integration, you have to process everything. Now, I would very much argue now from learning the hard way, and I have some patients we work with where we've both gone, right, enough. There often is just too much, and to go through it all, A, would take forever, but secondly, dissociation is there for a reason, and I think we need to respect it in some respects. If you are going to be doing the processing, actually using an element of Parnell's attachment focus is very helpful, but equally I like aligning that with Dolores Mosquera's sort of EMDR approach, where you still use more of the standard protocol, because actually a lot of these patients may not have the concept of a positive, they may not have a positive version of themselves. So to not necessarily have the patient look for a positive cognition, which often happens within the Parnell approach, actually for some of these patients isn't helpful. And then lastly, which we really don't have time for, but I'm very aware of trying to make sure we've got good time for the video, is actually then getting into the sort of more specific sort of systems-based work. And for me, that's a whole different session in itself. But I'm hoping that has been useful for you. Very last screen, if you have got a DID patient, the language is very important. The patient themselves, you want to get an agreement with them as to how they refer to themselves, if we're referring to the system. And then the parts themselves, there are multiple names, as you can see. What do they want to be called? Be guided by the patient. Karen, as you'll find, prefers parts. There are other things who don't. A real particular note in terms of legal standards in clinical notes, as I've said here, if you have engaged with other presentations of the patients and they happen to have names, make sure that you reference the part of the patient who refers to themselves as this, or a bit like I've said up there, because otherwise you'll have an entry of lots of different names, which gets very confusing. But again, a discussion for another time. I hope I haven't rushed too much. I hope it's been all right to listen to. I'm not sure I want to listen to it myself, but we'll move now to the video with Karen, which is just amazing. One of the most unwell patients I've ever worked with, to be fair, and so delightful that she's now doing so well as she is at the present time. Very much thanks to her psychotherapist who's been working with her. But I hope this has been a benefit, and happy to receive questions via email. Thank you very much.
Great. Well, I don't know about others, but I thought that was a really, really helpful presentation from Mel. So thank you very much to Mel for that. As Mel said, Karen has very kindly agreed to appear in an interview with Mel, and I'm going to move on to share that with you.